how do you want to look after the surgery? So this woman said to me, I want to look 16 again, right? So she didn't want ptosis, okay? So I decided to do the wise pattern scars that I use for my breast reduction on this patient. I think she looks pretty good. Then you say to yourself, well, why did you bother with Allerderm in this case? And I will tell you the reason is because I've got an 800 cc implant in there, and I need something to support that implant other than her native tissues, right? Especially if she's got a lousy serratus or, you know, or inframountain fold area. And here she is, she's about a year out, and I think she looks good. Just to show you all kinds, right? This is a smaller breasted woman who has an augmentation in the opposite side. One thing you can't appreciate is that lateral area is where the biopsy was, and they took her nipple plus everything. Another one where support, I think, is important, especially when you're gonna have a large area skin resection like that. Larger breasted still, high BMI patient. I give a talk on use of tissue expander and implants in high BMI patients. I think it can be done. I think it just requires incredible attention to technique. I think it's talking with the patients about their expectations and things like that. And this is a bilateral reconstruction with good, I think, good symmetry and good inferior pole projection and whatnot. So concluding, you know, what are the benefits of Allerderm in the breast? It stabilizes the pec. It avoids submuscular dissection inferiorly. It gives you support for your implant and your expander. It defines the pocket and border. I think that's the key. A little less painful because you do a little less dissection. This is the key, actually. More consistent outcome. I can readily predict what my results are going to be without having to put much thought into adjusting things much from case to case. Better aesthetic results, there's no question about that. And then I used to go back on my second stages, and like I said, I used to do capsulotomies and capsulectomies and sort of tearing the whole inferior pole apart. Now I don't do that anymore. I almost take the tissue expander and pop it out and I put the implant in. Almost that's all I do. And what that yields is less complication rates with the second stage, which is a whole other discussion for another time. Very quickly, if you look at my data stratified by radiation, okay? So this is the first set with the Allerderm, okay? You have 12 patients that were previously radiated, right? Those were lumpectomy failures that had had radiation and now coming back for a completion mastectomy, or 21 breasts that were radiated postoperatively. And I don't think it makes a difference whether, if you're doing a tissue expander, whether you know they're gonna get radiation or you don't know. It's the same thing. And if you look at the complication rates, a couple of things come to mind. First of all, if I didn't have radiation, I'd almost have no complications. So radiation is the bane of our existence. But also, if you look at the last line, all of my capsular contractures were in the previously radiated patients, and none in the postoperatively radiated. And what that means is clearly something's turned on with that radiation that definitely has an effect on capsular contracture. When you look at my Stratus results, just for comparison, it's exactly the same. Lots of complications in the radiated patients, more than in the not. And also, all of the capsular contractures are in the previously radiated patients. So what does this mean? And in the US, we're not allowed to say this, but I can say this here in Israel, that Allerderm probably has a protective effect against capsular contracture when you use it in the breast for those patients that are going to get radiated postoperatively. This is not something we necessarily expected to find, yet all 6 of us who started on this trek together will absolutely tell you that's what our results show. And if you go back to my data earlier, you look at the rate of capsular contracture, you know, we're talking about 2 to 3%. If you look at the literature, you know, previously, prior to Allerderm, you're talking about some people reporting 40 to 50% capsular contracture rate, depending on how they were defining things. So this was a, you know, so I think a major find that we didn't expect to find in using Allerderm. And with that, I will leave you, and I look forward to your questions. Thank you very much.
Scott, what about a direct-to-implant approach?
So I do it in about 20% of patients. You know, we still have the opportunity there to do both. In my hands, I think if I get, you know, listen, 2 shots at it is always going to make it better, right? And if you look, and if you look at the people who have published, like Andy Salzberg probably has the biggest series on direct implant in the US, his take-back rate is about 35%. Now, you say to yourself, well, you're taking 100% back with a tissue expander, and you're only taking 35% back, and that's pretty good. But, you know, perceptions are different, right? You know, When I know I'm gonna take somebody back, it's scheduled. It's a lot different than telling 35% of the patients. So a lot of that has to do with, you know, marketing and things too. But Andy does all direct implant, has good, very good results. He's a very good surgeon. I think that, you know, market conditions, healthcare conditions are gonna dictate that's probably the way to go, because we're gonna wanna use the money saved and show that to people so that we can get something somewhere else, hopefully. But so that's what I've done. I will select, listen, I get a woman, bilateral prophylactic mastectomy, nipple areola sparing, because she's BRCA positive, direct implant. I get a B-cup woman who's gonna have bilateral, whether it's prophylactic or not, even if it's not nipple areola sparing. Those big D cups, no way. Those are gonna get tissue tremendous, because I need to, you know, you need to be able to work with that. And, you know, when I talk about my high BMI patients, you gotta resect the skin appropriately and things like that. So there's more work to be done. But I think direct implant's a perfectly good operation, and if it works.
Okay, then maybe we'll do a little bit more questions after, but thank you, Scott. And thanks for not taking all of mine. Perfectly, and I didn't do the mechanics component, and it's perfect for the clinical setting. But some of the stuff that you showed, you know, part of it is, you mentioned inflammation, and I think inflammation is one of the biggest components of why AlloDerm is a good product for this usage, and I think I'm going to be able to show you that and why that is. So maybe first off, introduce myself again as Tani. I think only, like in this audience, easy to appreciate that Nathaniel is Netanel in Hebrew, and that's where my nickname Tani comes from. So feel free to call me that. So, you know, looking at the results that Scott showed, and especially that case where he showed you after it's been incorporated for some time in vivo, you can see what we like to call regeneration. So when we talk about what that means for LifeCell, that means restoring and maintaining structure, function, and physiology. That's what we like to see, and we like to expect that the body will do that on its own if we provide the right template for it to happen. So this idea of intrinsic tissue regeneration is a process that happens during fetal development. It happens that if there is damage to a fetus, I think it's well known that fetal tissue will heal without scarring. That happens through a process where these cells are attracted to the site, signals tell the cells what tissues to make, and they'll grow that tissue. This is an example where a fetus had a full thickness wound defect, and after it was born, that healed up completely. You can see in that photo, there's absolutely no evidence of any scar whatsoever. In contrast, if you look at a repair process is very different. It's a critical process that allows us to heal, but it allows us to heal in a way that there's a tremendous amount of scar, there's contracture, there's pain, and it's not a very nice cosmetic outcome either. So this repair process, which is obviously very important, otherwise we'd bleed out every time we had a paper cut. It's a very complex but well-studied phenomena. To simplify it down to a couple of elements, what happens early on is there's a fibrin scaffold clot to keep you from bleeding out. The inflammatory process starts to remodel that clot into a scar. So that's fibrosis, leads to a scar, which is essentially a disorganized collagen matrix that doesn't have the homeostasis and physiology of normal tissue. In contrast, if we go back to regeneration, if we go back to fetal development and look at how that happens, there's three fundamental components of how that happens, as I mentioned briefly. So there's stem cells that are signaled, there's signal molecules within the body that instruct the cells what to do, what tissue to make, and then there has to be a matrix that those cells are bound to, that those cells work on and work with. So, you know, our approach is that the cells and the signals are there all the time. So if they're there in fetal development and they're there when you do scar or healing responses to traumatic injury later in life, then the difference really can lie in the extracellular matrix itself, the tissue or the matrix scaffold that those cells act on. So our approach is to take that matrix and say that the best matrix for that to happen in is your native tissue. Now there's some issues with transplanting native tissue, so processing that tissue in a way that it maintains all of the components that we can, the fundamental biochemistry, the structural integrity that Scott talked about. It's a very complex structure, but if we can do that, then we believe that we can be a template for regeneration for the body. And if you think about it, actually, when I talk about fetal development as being a place for regeneration, in fact, if I asked you whether your skin today is the same skin you had 5, 10 years ago, and you thought about it a little bit, you'd realize it probably isn't. And that means that what we're actually doing is regenerating our tissue all the time, which means that that template, that tissue that we have, the cells are constantly being signaled and acting on that matrix, breaking it down and rebuilding it so that you can have physiologically natural tissue for the long term. So what we do with Alloderm is we remove the cellular component so we don't have a rejection response. We retain the biochemical components, the collagen proteins, the glycosaminoglycans, and other components of the matrix, elastin, which provides that stretchiness that Scott talked about, but preserve the matrix in its intact form so that those structures actually are more native and can be recognized by the recipient as like host tissue. If we do that, we can get to supporting revascularization, repopulation, and eventually regenerating into normal tissue. So there's a lot of biologics on the market, and you know, I'm not going to go through this list, and this list is not even complete. Alloderm is on there, but there's like 25 plus other ones, and there's probably another 20 since this list was published in the literature a couple of years back, but they're not all the same. So if what I'm describing is true, then really it's about how we process that tissue. A lot of those tissues actually come from human dermis, just like Alloderm. So what we believe is that in order to support regeneration, you have to do, as I said, is modify the matrix as little as possible so that it can be recognized and have a positive recognition by the body, be repopulated and revascularized into host tissue. The alternative is you can have a resorption response or you can have an encapsulation response, and the way you would get that is if you modify the tissues to an extent where you create enough damage, it's recognized as a foreign body, it's not recognized as host tissue, and if it can be digested by the body, it will resorb through that inflammatory response, that repair mechanism that we talked about, leads eventually to fibrosis and scar formation and contracture, and hence the issue around capsular contracture. Or if it can't be digested, and I'll talk briefly about that also, then you'll have a foreign body response. So I know that there are other meshes even beyond biologics that are coming to market, synthetic materials, and they can't be digested by the body. So they will be, the body will try to extrude them. It will have an inflammatory response around them, a classic foreign body response, sort of like getting a splinter and the body just wants to spit it out. So I'm going to show you what that looks like. This is dermal matrix before it's processed. It's a histology slide of a dermal matrix. If you cross-link the material up on the right, it'll look completely different. It's the same type of histological section of a cross-linked dermal material, in that case from a pig. Or you can extract the material heavily during its processing as you attempt to remove the cells, but you modify other matrix components as well. Looks completely different. That example is Allomax. In the middle, if you do a controlled process that we use at LifeCell, we'll remove the cellular components. You can see that they're missing, but you can continue to see the structure essentially is the same as the native collagen matrix. Now that's just a picture, so just being a picture and looking like dermal matrix doesn't necessarily mean it is dermal matrix, so I'll show you a little bit more. If you look at the ultrastructure, this is scanning electron microscopy. The top is a little higher lower magnification, and the bottom a higher magnification. You can actually see the fiber bundles, and that's the native dermal tissue. If you look at some of the other tissues that come from that same source after they've been processed, Allomax and Flex HD all the way on the right, they look completely different. They've completely melted out. You don't have the pore structure that you see on the top panel, and you don't have any of the collagen fibers that you can see on the bottom panels. In contrast, if you look at the Alloderm matrix using the same scanning electron microscopy, you see what looks essentially as the same structure as you see in native dermis. So the ultrastructure is maintained. Now again, that's just structure. I just want to go beyond that. One of the things we do to evaluate whether it's actually intact. One of the purposes of intact is that it should regenerate. So in order to regenerate, fibroblasts have to populate that tissue. In order for fibroblasts to populate that tissue and remodel it, they need to break it down. So the natural process of breaking down tissues by fibroblasts is through their migration process, which is an enzymatic process. They actually degrade the matrix as they walk into it and replenish the matrix over time. So in order to do that, they need to be able to break down the tissue in a normal way. And if they can, then they'll be happy with it. So we do a kind of contrived experiment where we'll look at how enzymes break down our tissue in the lab. When we do that, we find, not too surprisingly, that over time a cross-linked extracellular matrix will not be able to be broken down by those enzymes. On the contrary, if you have an extracted extracellular matrix like I showed you already before histologically, they're very quickly broken down by those enzymes, perhaps too quickly. And maybe you've already guessed that the middle line is an intact extracellular matrix. That's the alloderm curve compared to native dermis when it's being broken down by these natural collagenase enzymes. So if we go back to the repair process, that inflammatory process I talked about earlier, largely driven by macrophages. Now, macrophages are essentially activated monocytes, so blood cells. They get activated and they run this cascade through the repair process that leads you to scar, fibrosis and scar. And along that pathway, they'll also turn on myofibroblasts that allow that scar to contract. So what we want to know, the next step is, okay, so we know it's intact matrix, but is it biologically relevant, that intactness? In other words, when cells are in the presence of this matrix, are they pro-inflammatory or not pro-inflammatory? So what's nice is we do a lot of this work ourselves in the lab, but it's really nice when other people do the work for us, and they publish independently. So this study was published, a relatively simple but elegant study, where Dr. Orenstein looked at culturing whole blood monocytes in the presence of different tissues like alloderm, Allomax, and Flex HD, and then looked at whether those blood cells were activated and started excreting the cytokines, inflammatory cytokines that are typical of the macrophage in that repair process. So what he found was, and published on was, and I'm just showing the data on alloderm, Allomax, and Flex HD here, is that when those cells are in the presence of that matrix, they are activated in the presence of Allomax and Flex HD, and almost not at all with alloderm. So obviously different cytokines having different profiles for different materials, but all very significantly elevated. So the next question is, well, so we can show that in the lab it's actually relevant to how cells react to the tissue, but is that sufficient? Does that impact the actual healing response in vivo? In order to look at that, LifeCell developed a non-human primate model. We did this in the early 2000s. We published on it to establish it in the literature as an effective model for evaluating the immune response to the tissue. So even though, well, this model, as I'll show you, is actually in the abdominal wall space, it's actually an immunology model. It's not a repair model, but we're putting it into old world primates that have a lot of homology to humans, so they're the closest immunologic response that we can find to try to mimic what's going on in the human condition. And that would allow us to look at also a longer term implant. So we try to implant into cross species, unless you've done some modifications, which we actually do with Stratus, you will get a rejection response. You can't look at these materials long term. So if you look at small animal models, it'll typically be a month, but then you don't really know what's going to happen in the long term. And we're talking about remodeling over time. We want to know what it looks like 3 and 6 months out. So this model is basically a full thickness defect in the abdominal wall. We implant, in this case, the biological mesh. Could be any mesh. We actually have done other meshes. Explant the tissue at different time points, and we can look at what's repopulating the material and what the inflammatory or non-inflammatory response looks like, and how the tissue is turning over. What we found is that's the implant at time 0, and this is alloderm now 6 months out. And it looks very much like, I think, with what Scott showed you already that you see in the clinic. Sort of the punctate bleeding that starts to come through, and it looks like tissue. So if we compare that to what we see with other tissues that we've implanted in the exact same model, Allomax and Flex HD, they don't look the same at all. They don't look like they've been remodeled. They look like they're starting to resorb, and I'll show you the histology that indicates that even more so. And then a first look at a synthetic. Essentially, this is Seriscaffold. I'm not sure if people have heard about it here. And that's I'm using that as a surrogate for essentially any synthetic mesh. And what we find is, so the alloderm response is, as I talked about, a regenerative response. So, out of 2 weeks, we've already got so there's some small amount of inflammatory cells there, but there are also fibroblast cells and some early capillary action starting to be created. It's getting a little bit more mature at 1 month, but again, we're able to take this model out to 6 months, and you can see a completely remodeled matrix. You can see spindle-like fibroblasts that are healthy in that tissue, and a completely different structure than what went in, as I showed you the basket weave of dermal matrix, and now it's been remodeled over time. If we look, in contrast, at the resorption response, we can look at Allomax, 1 month, huge inflammatory response against the tissue that's on the top part of that slide on your left. And then 6 months later, the inflammatory response is still there, and the matrix is being completely degraded, and there is no dense collagen fibrous matrix there present. So it is being resorbed. And we look at Flex HD, we see essentially the same thing. Not the best slide, but in the top left corner of that slide, you see the inflammatory response against the tissue. And then at 6 months, it's this continuous, chronic, massive inflammatory response against the tissue, still there and resorbing the tissue as it goes and kind of eats through it. If you look at synthetics, so I guess there's some confusion. I've often heard people say, well, you know, since it came from a biological source, so it's sort of biologic. So none of the synthetics are synthetics. They're foreign bodies. They don't have any of the signaling mechanisms. They don't have any place for the cells to adhere in a natural state. They don't have a biologic response. They're seen as foreign bodies. And you know, if you look at it microscopically, not surprised, it doesn't look like tissue at all. The pore space that we're talking about is not at all the kind of pore structure that you have in the ultrastructure of alloderm or normal dermal matrix. So what you see in terms of the biologic response is a massive inflammatory response that's trying to eat up these fibers, but it can't. If you look at, as I mentioned, the macrophages are stained with CD68. This is a CD68 stain that shows how much of that cellular infiltrate is macrophage trying to digest or phagocytose those fibers. And if you look at alpha smooth muscle actin, which is a marker for myofibroblasts, you can see are also highly positive there. So the fibroblasts that are going toward that site are also being signaled and being turned into myofibroblast-like cells that are capable of contraction. And that is typically what they do with synthetic materials. So again, just to reiterate, there's a regenerative response with alloderm, there's a resorption response with these other matrices that have been modified, and then you have a significant encapsulation response with the Seri scaffold or other synthetics. So I probably don't need to, you know, reiterate this given the time constraints that I have. So I'm going to just move on and just really briefly mention, you know, so our mission is to advance surgery and improve patients' lives. We want to continue to innovate in the area of regenerative medicine. So I just to mention briefly, Revolve is the product that we use to help surgeons with their fat transfer procedures. I'm not going to really talk about that. We've launched that in the US now a year and a half, 2 years ago, and it should be coming soon to Israel. And then more recently, just this past year, we started to see the market with a new matrix product called Artia. Just really briefly what Artia is, I call it kind of the next generation matrix. So while alloderm is a human tissue product,